Good evening, dear vets. At the first, let me thank Dr. Vishal Sharma and Kanika Sharma for being very patient with me and working along with me to render this CE program without any problems. So today's topic is canine liver disease. I'm really, sort of very apprehensive on taking this topic because this is my PhD topic. Apart from that, I always see that I'm sorry if I hurt anybody's feelings. I have my general opinion on this disease is none of the veterinarians, at least 95% of the veterinarians, do not know anything about liver disease, do not diagnose liver disease, do not treat liver disease the way it has to be treated. This is my personal opinion. Please don't get upset if I say something which is contrary to truth. Okay? Because why I say this, to come to etiological diagnosis of liver disease, one must have a very good pathologist. And you should be able to take biopsy and send samples and get an excellent report. Okay, otherwise, it's very, very difficult to have, critical diagnosis. That is the reason I said that most of us do not know how to diagnose liver disease. However, most of us always blame the liver for anything. If your pet is anorectic, say liver is done. If the pet has got ascites, liver is the one which is responsible. The liver has got jaundice, liver is the one responsible. But most often, it is not so. So, it's a sympathetic organ. It's so sympathized with all other organs, it shows up the problems of other organs as its own. And therefore, we are misled. Okay, this is overall view about canine liver disease because liver has got multitudes of functions. It has got protein metabolism, carbohydrate metabolism, fat metabolism, storage of most of the important proteins. All bleeding, clotting factors are produced by this when detoxification is done by that. So invariably, all immunomodulation is done by liver. So invariably, all the things are done by liver. Therefore, when liver is diseased, you have so many clinical signs which are non-specific and happening, which we are unable to put it into a pathognomonic diagnosis of liver disease. That is the reason we are misled. Not that we are not skillful, but unfortunately, this aspect of the liver, which is confuses us to a very large extent. Okay, with this small background, let me start. I would be more than happy if at least 10% of this today's lecture goes into your practice, which is very important. Okay. So as I told you, liver disease is a paradoxical thing and it's a multifunctional organ. Therefore, it shows multitude non-specific clinical signs. And it shows similar signs in primary and secondary hepatic diseases. So this is the biggest problem in diagnosing liver disease. Most often you have secondary hepatic diseases because all the blood from this splanchnic region comes to the liver and therefore liver shows up sudden enzymatic increase, and therefore we always think liver is the one which is problematic. So that is the reason we are not able to differentiate between primary and secondary hepatic disorders. So if you classify liver disease, you can classify them based on acute and chronic. Acute hepatitis is a single episode of any injury to the liver. It shows some signs, but subsequently it regenerates itself. And chronic hepatitis, there's a problem is ongoing, and therefore you might have sequelae of a lot of things happening because of a chronic hepatitis. You can say that it has got a metabolic component, like alpha-1 trypsin activity deficiency, erythropoietin deficiency. All these things comes under metabolic. Toxic, most often drugs, especially anti-epileptic drugs, and of course your carprofen. All this can cause acute or chronic hepatitis. Copper is another biggest problem in liver disease. Copper storage disease is very common in human beings, but it's not so common in dogs. But nevertheless, certain breeds like Wellington Terriers, Dalmatians, Labradors, Dobermans, these four dogs are highly prone for copper storage disease. We'll see what it is later. Then immune-mediated, liver disease. Any other immune-mediated diseases which is happening elsewhere, they can have similar problem in liver disease also. Immune-mediated problems. Infection can be, leptospirosis, leishmaniasis, rickettsial. The most important thing which we come across daily in our practice, E. canis and babesiosis. This can cause chronic hepatitis. We have never ever thought, I think. So this can definitely cause severe hepatitis, chronic hepatitis. Then, of course, your myocard, mycobacterium, many other bacteria. Then histoplasmosis. Then protozoal infections, Bartonella, kennel cough, and of course viral, like ICH or your adenovirus or canine distemper virus. All these things can also cause chronic hepatitis. Not, of course, viral disease is very less common, unlike human beings. Human beings, viral disease is the number one cause of chronic hepatitis, or what is called as chronic active hepatitis. Hepatitis A, B, C is classified different ways. 5 hepatitis are there in human beings. They're all viral diseases, but we don't get such problems. Our ICH is not the problem in the liver. So it doesn't go into chronic active hepatitis like human beings. So the etiology can be said as infectious cause and non-infectious cause. So that a broader understanding can be there. As I told you, viral, adenovirus or ICH or canine distemper, this can cause infectious hepatitis. Bacterial, mostly it's a ascending infection from the splenic circulation, which is the main thing. Or you can say leptospirosis or leishmaniasis. Parasitic hepatitis, of course, some certain flukes cause obstructive problems and cause infectious hepatitis. Non-infectious cause copper storage disease. You have got primary copper storage disease, which is a genetically owned disease, like in Bedlington Terriers, or secondary copper storage disease, which is very common in Dobermans and Labradors. Drugs and toxins, as I already told you, drugs like anti-epileptic drugs and other toxins. Toxins are always from the intestines. Most of the aflatoxins or endotoxins from the GI tract comes to the liver and causes non-infectious cause of liver disease. Endocrine diseases most of the times can cause liver diseases. Bile duct obstruction, either bile duct carcinomas or bile duct tumors or simple severe pancreatitis can cause bile duct obstruction. Then last one is portovenic shunt, which we don't see much in our countries. Though there are a lot of reported incidents, anyway, I haven't come across anyone so far in my career, because we do not have the diagnostic criteria to diagnose portovenic shunts. That is the reason we are not able to see lots of cases. Otherwise, lots of such cases must be passing on through our head. Anyway, we'll see about portovenic shunt later. So what happens when there is going to be a hepatic dysfunction? Okay, so you should understand that liver has got a great capacity to regenerate. Okay, it can regenerate. 75% of the rats liver dissected within 15 days gains normal shape. So that is the extent of liver regeneration in most of the species. So the normal insults on day-to-day insults, there'll be an hepatic injury, but immediately they'll become all right the next day. When it is widespread and very acute, you may have some problems, or it can regenerate. Widespread, if it is not regenerating, if it is going to be a chronic ongoing insult to the liver, then it becomes a chronic hepatitis, which if not controlled becomes fatty liver. Fat gets accumulated, pressing the hepatocytes. And if at that stage it is not controlled, this hepatocytes start dying. It is called necrosis. And at that stage, if it is not stopped, fibrous tissue intervene between the hepatocytes and fibrosis occurs and later on end-stage cirrhotic liver, where no more function is possible by the liver. These are all the consequences of hepatic dysfunction. Okay, what are the other consequences of liver disease? There can be increased bilirubin. So what happens, why there should be increase in bilirubin? There can be prehepatic. That is, when there are a lot of RBCs are lysed, it can produce more of bilirubin, and that can cause increase in bilirubin. That has got nothing to do with liver. Then hepatic, where the hepatocytes are unable to take up the bilirubin because of its dysfunction. And next one is intrahepatic cholestasis. When there is going to be, swelling of the hepatocytes, it is going to crush the bile duct and cause intrahepatic cholestasis. And therefore, there will be increase in bilirubin. Post-hepatic, naturally, there will be increase in bilirubin because the bile duct is completely blocked because of tumor or pancreatitis or parasitic larva. They can completely block the bile duct and cause post-hepatic increase in bilirubin. So, liver dysfunction, when there is increase in bilirubin, you should think about prehepatic, and you should think about hepatic, and you should also think about bile duct canaliculi being blocked. Next is bile acids. Bile acids will be increased in liver dysfunction. Specifically in portosystemic shunts, it's a pathognomonic biomarker for portosystemic shunt. In all other chronic liver disease also, bile acids are more important marker than anything else. That is, specificity is more in bile acids. Okay, whereas all other tests, specificity is very low. Sensitivity is high, but specificity is low. Bile acid sometimes is reduced where there is going to be steatorrhea. Okay. Next, metabolic consequences. What happens to metabolic system because of liver dysfunction? There's going to be a hypoglycemia. There's going to be because of lower glycogen storage, because hepatocytes are one which stores glycogen. So once it is not functional, then glycogen stores will be depleted, and therefore you have hypoglycemia. Gluconeogenesis is affected. Insulin is degraded, and in end-stage liver disease, you will have severe hypoglycemia. So whenever you have hypoglycemia, think about liver disease. Hypoalbuminemia. So this is again a very characteristics of liver disease. Albumin is produced by the liver, and therefore, when there is going to be end-stage liver disease, there's going to be a severe lowering of albumin. That is, there's going to be less than 1.5 gram per deciliter, and at that time you will have ascites. But your globulins will be increased. Your protein level will be normal. Only your albumin will be. We will see how to correlate this protein albumin. So hypoalbuminemia is a consequence of end-stage liver disease. You don't get in the initial stage, end-stage liver disease. So most of the times we always see this ascites. So circulation, what are the consequences of circulation? You know what is a portal circulation? So the blood from the intestines, large intestines, small intestines, or all other, spleen, everything gets collected and goes to the liver, there where it gets detoxified and goes to the heart through the vena cava to further purification, oxygenating, and then further circulation. This is called portal circulation. Okay, the pressure involved in this blood traveling through the vessels from the abdomen to the liver to the heart is called portal circulation. And when there's going to be a pressure, some block in this circulation, there's going to be an increase in hydrostatic pressure. So that is called portal hypertension. It can be pre-hepatic portal hypertension, or it can be hepatic portal hypertension, or it can be post-hepatic. We will see how to see all these three. With how to diagnose the problem regarding hydrostatic pressure, we will see. Next is oncotic pressure. Oncotic pressure is the one provided by the protein, and most importantly, albumin. So whenever protein is lost, you will have reduction in oncotic pressure and you will have ascites. So what are the chances? It can be protein losing nephropathy, through the kidneys because of end-stage kidney disease. It can be protein losing enteritis, where there's loss in the motion or malabsorption, or it can be due to liver producing less of albumin. So you can have either kidney or the liver or the liver, kidney, and low protein intake. All these things can cause low oncotic pressure, and you can have ascites. We'll see how to diagnose that also. The difference, the problem encountered in oncotic pressure and hydrostatic pressure. And sodium water retention happens in a cirrhotic liver, where there's going to be a dilatation of the veins, and there's going to be sodium water retention by the renin-angiotensin part of the kidney. So that is the reason you have sodium water retention. That is end-stage cirrhotic liver. Okay, this is about ascites. Portosystemic shunt, which I already told you, the circulation existing between the splanchnic area, which goes to the liver, from there goes to the heart, from there it is pumped out. This is portosystemic shunt. This also we will see later. So these are all the circulation problems encountered in liver disease. Then the liver is most important in detoxification. So whenever it is not able to detoxify, the normal ammonia, the mercaptans, which are all absorbed from the GI tract, they go to the liver and they are not detoxified because it is dysfunctional. It goes to the brain, and you have hepatic encephalopathy. So what are the clinical signs of hepatic encephalopathy? Circling, head pressing, all those things we will see how to diagnose them and how to see how to treat them, hepatic encephalopathy. Drug metabolism is completely affected when liver is affected, because most of the drugs are metabolized by the liver. Okay, so we will see how to think about the consequence of liver for the drug metabolism. So most of the antibiotics, your drug dose should be less, because they got liver dysfunction is there. So because it cannot metabolize as a normal liver, so your medication should be highly monitored during treating liver disease. Okay, other problems encountered as a consequences: bleeding. The most important aspect is again this one. Okay, because the clotting factors. So it is involved in all the process of the bleeding, both primary hemostatic disorder and a secondary hemostatic disorder. You know what are the primary hemostatic disorder? It's purely to do with the platelets. Secondary hemostatic disorders purely to do with the clotting factors. We always confuse this, and with the result, you always treat epistaxis with a lot of styptics, which are waste. So primary hemostatic disorder, there's only problem in the platelets, and platelets are produced by the liver. Okay. Again, all the anticoagulations, they are produced in the liver. Protein involved in fibrinolysis is is done by the liver, and thromboprotein is produced by liver. So you have bleeding problem, you have a clotting problem, you have the clot is not completely made because lysis is affected. So you have all the problems. You have embolism, you have bleeding, and vitamin K malabsorption. Whenever there's going to be obstruction, there's going to be bile is very important for vitamin K absorption. So all your cholestatic disease, you'll have vitamin K malabsorption. Okay, so portal hypertension. Portal hypertension, I told you about ascites. In that case, when there is portal hypertension, when there's increase in pressure in the circulation, there will be GI bleeding. This is not very true to dogs or pets like cats. It is very true to human beings. You always see cirrhotic liver patients always, vomiting blood. That is because of the vessels, the esophageal vessels, they burst, and they start vomiting blood. That is because of portal hypertension. Very common in human beings, not so common in dogs. But nevertheless, you do have GI bleed in the form of mucosal turnover problem, and that is the reason why we have to go for like cimetidine, famotidine, or pantoprazole, all those drugs because of GI bleeds. Polyuria polydipsia is a rare problem in as a consequence of liver disease. So now we'll come to see how to diagnose liver disease. Okay, so history is somewhat important because there's a history of the pet being on the diet of anti-epileptic diet drug for a long time. Then you can suspect, or it has got a hip dysplasia and it is on carprofen for a long time. Then you can suspect liver disease. So history is very important. Or again, history of poorly kept kennels where rats come, leptospira. So these sort of histories can give you some diagnostic clues for the liver disease. Signalment, I told you. So that is more important. First, the breeds. Breeds like our country, most common Dalmatians, Dobermans, and Labradors must be always thought about of liver disease. Okay, primary or secondary liver disease. Then clinical signs. As I told you, a lot of clinical signs will be exhibited, right from not taking food to vomiting to diarrhea to steatorrhea to it can show ascites, it can show jaundice. Definitely lots of clinical signs, but nothing is pathognomonic. You may think jaundice, but it need not be liver. You may think ascites, it need not be liver. So that should not be crowded. It should not cloud you into thinking it is liver. So what are the breed-specific liver disease? Bedlington, primary copper storage disease. There are genetic testing available abroad. Because since we don't have much Bedlingtons, we don't really bother about copper storage disease. So copper storage disease is diagnosed by histopathology. West Island Terrier, chronic hepatitis and cirrhosis, or which very common in West Island Terriers. Dobermans, chronic hepatitis, cirrhosis, and secondary copper storage disease. Whenever Dobermans, are not well, you always should think about secondary copper storage disease. So whenever you have slightest doubt that the Doberman has got a mild increase in ALT, you start them on treating with anti-copper drugs like D-penicillinamide or at least vitamin C, which is easily available. That you can start in Dobermans and Labradors. Dalmatians, chronic hepatitis and cirrhosis. Labrador, chronic hepatitis. So the lobular dissecting hepatitis is very common in Labradors. Then Cocker Spaniels, chronic hepatitis and cirrhosis. Schnauzers, idiopathic hyperlipidemia. This is very common in Schnauzers. So the diagnosis of liver disease, the clinical examination, as I told you, icterus and ascites. Icterus is very easily visible. In case if it's if it is not visible, if there's going to be a pallor mucous membrane, as in hemolytic jaundice, then the diagnosis is directly there. Again, ascites, sometimes it can be a small quantity of ascites, but it's difficult to palpate and understand. But as you palpate from the ventral abdomen, as you slip your hands with pressure upwards, then you can find the intestines slipping through your fingers as if they have been applied with oil. So that is suggestive of even mild ascites. Otherwise, it's just ballotment and palpation and percussion. You can always diagnose ascites, or you can do a small abdominal synthesis and find out if it is ascitic or not. Then palpation, hepatomegaly is very important. There can be hepatomegaly. There's going to be hepatomegaly. The most often the problem could be due to a cardiac problem. Okay, and pain on palpation and ascites. These all can be palpated. Femoral pulse. Okay, this is again very important. Femoral pulse. Why? Most of the times your hepatomegaly and ascites is due to cardiac problems. So femoral pulse will give you a lot of clues on your cardiac status. So other clinical signs are anorexia, drowsiness, lethargy, phthallism, that is hypersalivation. Hypersalivation, if you see in a puppy or in a cat, most specific in cat, highly pathognomonic in cats, and there's going to be hypersalivation. It is highly pathognomonic for portoventricular shunts. especially a small puppy or small kitten vomiting after a bout of protein meal and showing hypersalivation. It's a classical sign of portovenical shunt. Okay, that is one. Then vomiting, changes in mentation because of hepatic encephalopathy, ataxia, again hepatic encephalopathy, weakness in hind limbs, disorientation, coma, seizures. They're all suggestive of hepatic encephalopathy. Because jaundice can be a problem from the liver. Ascites can be a problem with liver, but definitely not to a very large extent. I would rate ascites as a cause of liver is only about 10 to 15%. Most often it is post-hepatic. So how do you diagnose liver disease? First step, based on history, clinical examination and physical examination, differentiate hepatic and non-hepatic, whether it is a liver or whether it is extrahepatic problem or whether it is a cardiac problem. First, you should doubt whether it has got some inclination towards liver or not. Second step, breed predilection. I told you, terriers, Dalmatians, Labradors, Dobermans. Think about liver as a cause. Otherwise, don't have to think so much. Third step, enzymology. This is very important. We will talk about this more, but before that, we will see about what is the pathway of diagnosis. Third step, thrice increase in any one enzyme, say either serum alkaline phosphatase or ALT, if it is increased, or GGT is increased more than 3 times, you can think of liver. A progressive increase. Today you have seen after 2 days, today is 40 international units. The next day it is 80 international units. You should think about liver because ongoing injury is there. Then when there is increase in ALT, when there is increase in SAP, okay, then after doing this imaging, ultrasound, histopathology. Again, it's very, very important. I told you, ultrasound gives you a lot of, clues to a liver disease. Of course, you can always diagnose, focal disease of the liver, like a tumors or cyst or, stones. You can easily diagnose. Just you keep the, the easiest organ to do ultrasound is liver. So you can almost diagnose. But if you want to, diagnose chronic hepatitis, then you require histopathology. You should be skilled to take biopsy. I'll tell you how to take biopsy. And you should send a specimen where you can have a good histopathology report coming from. You can send there and then find out. Because that is the most important criteria for the final diagnosis. So this is regarding the the importance of biopsy. Okay, there can be I don't want to go through because most of us do not do biopsies. But anyway, when you have a biopsy and when you have seeing apoptosis remodeling, then lymphocytes, neutrophils, monocytes, all those things are there in the histopathology. Then it's inflammatory disease, primary inflammatory disease. When you have, along with minimal changes in the hepatocytes, histopathology. If it's a young dog, if you have ascites, if it has hypoalbuminemia, mean arterial pressure, and increased total serum bile acids, then it is lobular dissecting hepatitis, more common in young Labrador puppies. Okay, then if the inflammation is more and you have vascular proliferation, fibrosis, regenerative nodules, and there is a clinical seen is moderate to severe increase in ALT and normal or abnormal functions, then it is chronic hepatitis. And if there's going to be a regenerative normal modules more than less than 3 mm and macronodular more than 3 mm, then if the clinical signs increased total sign, serum bile acids, hyperbilirubinemia, hypoalbuminemia, and ascites, then shunts, acquired portosystemic shunts, and portal hypertension, and cirrhosis. And most important thing, secondary hepatic disease. This secondary hepatic disease is from the spontaneous circulation, most often due to endotoxins and bacteria coming to the liver through the vena cava and causing reactive hepatitis. It's called reactive hepatitis. Here, you have no much change in histopathology. You don't have fibrosis, you don't have necrosis, you don't have apoptosis. Apoptosis is remodeling. You don't have, but mild changes in inflammatory, lymphocytes, neutrophils, monocytes are seen in the histopathology. If you have mild changes with a normal, enzymes, then it is non-specific reactive hepatopathy, most often due to pancreatitis or most often due to GI problems, leading on to endotoxins, septicemia, and reactive hepatic issues. So this is which is very important, that you should have a good histopathologist to come to a final diagnosis, whether it is chronic problem, cirrhosis, or lobular dissecting hepatitis. In human beings, is called acute, hepatitis. Okay, and extrahepatic problems. To differentiate them, that is called, in the humans is called chronic active hepatitis. Okay, so here you require a good histopathologist. Now we'll come to laboratory evaluation. If one does not rely on pathology, he is ill-informed. If he totally relies on pathology, he is misinformed. Now, veterinary profession has gone to another level. So almost everybody is having, hematology monitoring equipment, and they are able to do in-house, analysis, everything. So they are not going to be ill-informed, but they will be most of the times misinformed because they just go by the values. So a single time increase in ALT, they will say liver has got a problem. Okay. So these sort of problems, if it should not occur, you should know how to, interpret laboratory results, which is very simple. So liver, I already told you, is a sympathetic organ. For everything, it will start crying. When the pancreas has got a problem, it will start crying. If the GI problem is there, it will start crying. So it is a sympathetic organ. So you should always think that it is not the main one to be affected. High sensitive and low specificity, most of the markers. If negative, it is true. If there is no ALT increase, there is no ALP increase, if there is no increase in bilirubin, absolutely true, there is no liver disease. But if it is positive, it need not be true. That is the reason it is got low specificity, most of the markers. And you have to differentiate between extrahepatic and hepatic disease. So now you have two types of tests. Those that evaluate injury to the liver. Okay? So whenever there is an insult to the liver, the hepatocytes liberate the enzymes. Okay? They are called cystosolidaric enzymes. Your ALT and AST. They are GGT. ALT and AST. And serum alkaline. These two are the one which is going to be elaborated when there is going to be an injury. Okay, but the liver's function is absolutely 100% fine. So what evaluates the liver function? Bilirubin, total protein. These are all the one which evaluates the liver. So the tests have to be completely separated into those which does injury and those which compromise the function. Because injury is not a serious problem. Supposing we have a toxin today, or if you take 2 or 3 large of whiskey today, tomorrow morning if you see your blood, your ALT will be increased. That doesn't mean that your liver is injured. It will regenerate the next day. So you need not worry about it. So we should know whether it is a test which we are seeing is injury or function. And collection tips. This is very, very, very important. Sometimes, we attach we just collect blood and send it, but other problems in between, we forget to see how much difference it can make. Most important, hemolysis. It should definitely be without hemolysis. So I was often thinking when I was an assistant professor, I was thinking, when you put a large gauge needle, 20 gauge needle, and without syringing, if the blood flows, it will not lyse. But I wasn't for shock when I went for my critical care to UK, where they said when you use a 20 gauge needle, blood rushes through that needle and gets lysed. So if it is always better if you remove with a syringe from a 23 gauge needle, this is better. You will not get hemolysis. So this is something which I learned much later in my life. Then age samples. So samples should be not aged. You should send immediately. Ictric samples are not good for doing injury analysis. Lipemic sample again are not poor samples for problems. A pancreatic disease, you have a lipemic sample. You need not waste your time on doing ALT and AST. And insufficient sample. These are all collection tips. So I told you, what are the tests which you do to evaluate injury? One is alanine aminotransferase, which is called ALT. Then aspartate aminotransferase is called AST. Many of us may not do aspartate because we think it is a muscle enzyme. But I will tell you why you should do aspartate. Then we got two more. Alkaline phosphatase. It's a cholestatic enzyme. The first two are alanine aminotransferase and aspartate aminotransferase, or cystosolic enzymes. They are in the hepatocytes. Alkaline phosphatase and GGD are in the bile duct and gallbladder. So they are called cholecystic enzymes. So whenever you suspect problem in cholestasis, then you do alkaline phosphatase and GGT. Okay. Otherwise, you need not do alkaline phosphatase and GGT. And interpretation also, you require to do alkaline phosphatase and GGT when it comes to stasis, when there's going to be jaundice, when there's going to be hyperbilirubinemia or hyperbilirubinuria, then you do alkaline phosphatase and GGT. Okay. Alanine aminotransferase. Please attach more importance to these next few slides, which gives you a lot of mistakes which we commonly make. Non-hepatic disease where there is increase in alanine aminotransferase. Drugs can cause increase in ALT. GI diseases, I told you, liver is a sympathetic organ. So any toxins which comes there can cause increase in ALT. Hypoxia or anemia can cause increase in ALT. Diabetes mellitus, Cushing's, pancreatitis. So all these things you should have in mind when there's going to be increase in ALT. So again, another one, the most important thing, whenever there is hepatic injury, alanine aminotransferase is going to be liberated. More than 5 times a reference rate should be your immediate concern. Otherwise, you need not concern. Okay, if it is less than 5 times, there are no clinical signs, please don't think liver has got a problem. Okay, if there are clinical signs and it is 5 times, then you should think. And persistent increase is a concern. Today you are doing, repeating the test after 2-3 days, there's going to be again increase. So from 40 to 80, that means there is an ongoing injury. It is a chronic hepatitis. So there is a concern. You should know one thing. Alanine aminotransferase elaborated whenever there is injury. But it is also elaborated when the is going to be becoming all right. When the repair also, it is going to be elaborated. So you do not know the ALT increase, whether it is due to injury or whether it is due to repair. So you should be very, very, very cautious when interpreting the results of alanine aminotransferase. So again, why we should do ALT and AST? This is again a very important question. So both increases in hepatic necrosis, and both are elaborated during hepatic repair. But AST returns to normal level immediately. Okay. Persistent increase in ALT and AST is a questionable problem. If there's going to be a severe increase in ALT and a normal AST, that means it is a mild damage is there to the hepatocytes. There is going to be double increase in ALT, and there is going to be a moderate increase in AST, then there's a moderate liver damage. And if the ALT is normal, if only AST is increased, then there's only muscle damage. There is no problem with hepatic tissues. Next important, alkaline phosphatase. Most important things, it's got a lot of other enzymes, it's increase in liver, it's increase in intestinal inflammation, all bone disease, growing animals, and it is also increased in diabetes mellitus and also increased in pyometra. So you have to keep in mind when you are seeing in a small dog, it can be because of alkaline phosphatase, because of growing osteocytes, or it can be a bone disease where there can be increase in alkaline phosphatase, diabetes mellitus, pyometra, intestinal inflammation, all this is alkaline phosphatase. There's going to be a 100% increase in normal level of alkaline phosphatase. If there's going to be a 100% increase, then it is a complete obstruction. So it's going to be a complete obstruction. And if there's going to be an intrahepatic cholestasis, going to be a mild increase will be there. Extrahepatic cholestasis 100 times, 10 times normal level in intrahepatic cholestasis. So you have to be very, very careful in seeing this. It is also seen when the pet is on steroids, there will be increase in alkaline phosphatase. It's called steroid-induced alkaline phosphatase. Or it can be Cushing's, again because there is hypercortisolism, Cushing's disease. So whenever you have alkaline phosphatase, rule out intestines, bone disease, growing animals, diabetes, pyometra, and Cushing's and steroid drugs. Then you can think about liver. There's got high sensitivity and low specificity. I told you what is high sensitivity and low specificity. If it is negative, 100% there is no problem with your cholestasis. But if it is positive, there's only 51% of chance that it is showing liver. 49% it need not be liver. Okay, you have to be very careful in knowing this. But if it is going to be combined with other, markers, then you will get a more specificity. We will see that in future slides. So serum alkaline phosphatase is increased in nodular hyperplasia of the liver. So nodular hyperplasia of the liver, there's going to be a how much of increase? There'll be 10-fold increase because there's going to be intrahepatic cholestasis. The hepatocytes, because there is going to be nodular hyperplasia, they'll be compressing the bile duct. There'll be increase in 10 times the normal value. Pancreatitis again will cause increase in serum alkaline phosphatase because it's got extrahepatic obstruction of the bile duct. It can be 100-fold increase also. And sometimes in old dogs, you have increase in serum alkaline phosphatase because the hepatocytes tend to press the gallbladder in old dogs. So there also you can have increase in serum alkaline phosphatase. ALT and SAP, if they are both together, if you see, so you should see them together, then it is highly suggestive of pancreatitis, diabetes mellitus, and hyperthyroidism in cats. So how many of us see this way? ALT and SAP, both are elevated. Think about these three diseases. Cats alone, alkaline phosphatase is highly suggestive of hyperthyroidism. Hepatic lipidosis is very common in cats and a very short half-life. That means what is short half-life? The moment the alkaline phosphate is liberated, it is metabolized faster. So that means if you see even a small increase in a cat, it is highly concerning with the problem, either hyperthyroidism or hepatic lipidosis, or it can be obstructive problem. So cats should be very careful. Smallest presence of alkaline phosphatase is suggestive of problematic. Gamma glutamate transferase. This is, I already told you, like alkaline phosphatase, it is also a cholestatic enzyme, and there are no bone isoenzymes, there are no steroid-induced isoenzymes, there are no intestinal isoenzymes. So therefore, it is more, marker for cholestatic disease than serum alkaline phosphatase. So GGT with serum alkaline phosphatase, highly specific, 94% is going to be true, positive. So it's to combine GGT and SAP is very good. When ammonia metabolism is affected, it doesn't rule out PSS. Serum bilirubin. So again, here also we'll have to be very careful. Non-hepatic causes of increase in serum bilirubin. So you should understand, the bilirubin, if it exceeds 2 milligram per deciliter, you have visible icterus. Till then, you don't get icterus. Okay, normal is around 0.7 milligram per deciliter. So after 2 milligram, it is seen in the mucous membrane. Before that, it is seen only in your test. So if it says 1.8, your pathology will say it is increased than the normal value. So immediately you will think liver is a problem. So non-hepatic causes of minimal increase in serum bilirubin, fever, starvation, sepsis, inflammation. All these conditions, you will have minimal increase in serum bilirubin. Not to the extent of having jaundice, but still it will have increased bilirubin. In horses, yes, even if the horse shows jaundice, you need not worry. Simple starvation will cause jaundice in horses. So we have to think about non-hepatic causes of increase in serum bilirubin. So bilirubin is again increased in cases of prehepatic problems, hemolytic jaundice. Okay, so what you will have here in a prehepatic hemolytic jaundice, you will have low hematocrit. Your PCV will be very low, your RBC will be low, hemoglobin will be low. You will have increased bilirubin. You will have normal bilirubinuria, but you will have increased urobilinogen because more bilirubin is sent to the distal process. So you'll have more urobilinogen. You'll have a dark colored urine, you will have bilirubinemia, and you will have anemia in a prehepatic jaundice. And many times you have hemoglobinuria because of lysis of RBCs. So if these three things are there, low PCV, increase in bilirubin, increased urobilinogen, and if there's going to be hemoglobinuria, it's a prehepatic jaundice. Hepatic, increased bilirubin, there will be increased liver enzymes, there will be bilirubinuria, and increased urobilinogen. All will be there, okay, in hepatic jaundice. Obstructive jaundice, there will be increased bilirubin, there will be increased bilirubin in urine, no urobilinogen, and alcoholic feces. Because fully blocked, you will have clay color feces. You have obstructive jaundice. Okay, here you will have increase in bilirubin, you will have jaundice, but your hematocrit will be normal, your PCV hemoglobin will be normal. So you have to always think about that. You have to combine your hematology with serum bilirubin. Don't see them separately. Serum protein, again very, very important. I told you, albumin is being produced in the liver. So there's going to be a low serum albumin in chronic end-stage liver disease. And there will be increased in globulins because of compensating, immune-mediated inflammatory disease. There will be increase in globulins. So your serum protein will be 5.8 to 7, but your albumin will be less than 1.5 grams. So hypoalbuminemia with hypergamma-globulinemia is a hallmark of liver disease. Whereas in protein-losing enteropathy and protein-losing nephropathy, you'll have total production, protein will be less. So that is how you have to differentiate. Cholesterol. It is a non-specific but second line of test which can be always done. So reduced in liver disease because not eating, so cholesterol is very less. Increased in biliary stasis, all cholestatic disease. Increase in Cushing's and diabetes along with hepatic enzymes. So cholesterol also will give you certain clues, and it will allow you to distinguish non-hepatic disease like diabetes mellitus or Cushing's from liver disease. Liver function test, ammonia tolerance test is not done nowadays because already you are suspecting liver disease. When you inject ammonia, it can go into a catastrophic event and it is time consuming and it is not done nowadays. So you need not bother about ammonia tolerance test. Serum bile acids, we should start doing this because we are not doing that. Many of the clinics, we are not doing this. In liver disease, especially portoventricular shunt is increased. 100% specific for shunt. That means if it is positive, it is shunt is 100% sure. So when I was working in Bristol, the veterinary doctor, practicing veterinary doctor will send a dog with serum bile acids increased. He will send it to the referral hospital. Why he is sending the referral hospital? Surgical possibilities are not there in a small clinic. Here, the moment it comes, they will inject a dye, find out where the shunt is there, and they ligate the shunt, and again take another X-ray to find out if it's ligated or not. And that is a big process. So that is what serum bile acids will produce. Fasting more than 25 millimoles, postprandial more than 30 millimoles per liter, or highly specific for liver disease. I told you the pretenders. So we are to always be careful with ALT and ALP. Though it is a liver enzyme, they are increased in pancreatitis, diabetes mellitus, hyperthyroidism, especially in cats. So whenever you see increase in ALT and ALP, think about pancreatitis, diabetes mellitus, hyperthyroidism. Bilirubin, anorexia, catabolic state, sepsis. Think about bilirubin. ALT, rule out cardiac disease. ALP with ALT, hyperadenocorticism, 100% correct. Okay, so we'll have to be very, very careful in knowing these pretenders. Ultrasound of the liver. I told you, for any veterinarian who has bought a new machine, the easiest organ to see will be the liver. And please don't think it is a great skill to do a normal, ultrasound. When you start doing, if you attend some coaching, or still better to work with human ultrasoundologists for about 1 month, where they see 30-40 cases per day, and get your eyes tuned with the differentiation between the shades of gray, black, white. If you are able, your eye is able to differentiate, then you are the best ultrasoundologist in your practice. So there are some windows where you keep this S1, easily you can see. Most of the focal disease you can diagnose by using an ultrasound. So I need not bother about much about this one. The two major blood vessels enter the liver. Portal vein carries most of the blood to the liver and contains nutrients. And of course, hepatic artery carries oxygen-rich blood to the liver. The scan head placed directly under sternum, often angled cranially. Animal should be in dorsal recumbency, and begin a transverse scan plan and set depth to see the diaphragm echogenic line. Then switch to sagittal sign to see all the lobes. And you can also do an intercostal approach where you can see much more lobes. So this is a very simple positioning. You can also do on a lateral, there's no problem. So size of the liver is assessed subjectively, not very pathognomonic. Homogeneous, parenchyma is homogeneous, uniform, interrupted only by portal and hepatic veins. Portal veins have echogenic walls. Understand? Portal veins have echogenic walls. White colored walls will be there. Hepatic veins, they will not have any wall. They will look like a black tube. Hepatic arteries are not usually seen. So echogenicity you should be able to compare how they are compared to spleen and kidney. In dogs, more echogenic spleen than liver. Liver is more echogenic than kidney. In cats, spleen and liver are same echogenic, and kidneys, they are much more echogenic than the kidney. Okay, texture, most coarse texture than the spleen. Portal veins, more echogenic than hepatic veins due to surrounding fibrofattic tissues, less visible with shunts, fibrosis, and cirrhosis. Okay, so hepatic veins best seen cranially near the diaphragm, as I told you about the walls. Then hepatic ultrasound, you can easily diagnose solid and cystic diseases, focal and diffuse diseases, portavenical shunts. With minimal experience, you can do portavenical shunts. Biliary stenosis, to some extent difficult, but nevertheless, if you start doing, you will be able to find the stenotic biliary vessels. Tumors, definitely you can diagnose. Hepatic lipidosis, because highly hyperechoic, so you'll be able to see hepatic lipidosis easily. Hepatic hepatomegaly, subjectively you can see, because wherever you keep, they can see the liver, so you can subjectively assess hepatomegaly. Cirrhotic liver is very, very easy. You have a corrugated end, not a smooth liver end, so you got a cirrhosis. So whenever you have hepatomegaly, what are your differentials? Steroid-induced hepatopathy, most important. So you have history, you have increase in serum alkaline phosphatase. In ultrasound, you have hepatomegaly, then think about steroid-induced hepatomegaly. Or it can be Cushing's, lipidosis, amyloidosis, diabetes mellitus, hepatitis, congestion, like supposing you've got congestive heart failure, then you can all these conditions you can have congestion and hepatomegaly, neoplasia and hepatomegaly. Nodal hyperplasia of the liver, you'll have hepatomegaly. The chronic tumor, you might have even less, shape may even reduce. Focal or lobar hepatomegaly, only one side is increased, or one lobe is enlarged, then is called focal or lobar hepatomegaly. Any metastatic disease, you can have some lobe bigger. Hematomas, you can see the contour diverting in hematomas. Abscesses, granulomas, lobar torsion, thrombotic vessels will increase only one lobe. The vein which is thrombotic, that lobe alone will be having a hepatomegaly. Small liver, severe cirrhosis, shunts, and fibrosis. Diffuse parenchymal disease, cholangiohepatitis, early metastatic diseases. So how do you find out diffuse parenchymal disease? The echogenetic pattern itself is, hyperechoic, fatty infiltrations, storage disease, toxic hepatopathies. You have diffuse parenchymal disease. The whole echo structure is disturbed. Ultrasound finding in lipidosis, you have hepatomegaly, hyperechoic, rounded borders, hyperattenuation. Inflammatory disease, diffuse hypoechogenic. So hypoechogenic means darker color. So how does it look in acute hepatitis and cholangiohepatitis? Hypoechoic and hyperechoic portal vein walls. Chronic inflammation, how it is? Chronic hepatitis, hyperechoic or mixed echogenicity. Cirrhosis or fibrosis, hyperechoic and small liver. Focal parenchymal disease, necrosis, neoplasms, cyst, granulomas, liver lobe torsions. How does it look in neoplastic disease? Diffuse, focal, multifocal lesions. You can't say. Can be diffuse, it can be focal, it can be multifocal in different places. Diffuse, if it is diffuse, is lymphoma or mast cell tumor. Benign nodules less than 1 centimeter benign. Malignant nodules, hypo or hyperechoic. They look like target lesions and poorly defined nodules. The borders will not be defined. So these are all cases of diffuse liver tumor. See, you can see the hyperechoic liver with small hypoechoic areas in between. So there's a mixed echogenicity where hyperechogenicity predominates. Okay, very clear, and you can compare the echogenicity with kidney. So lymphosarcoma of the liver. So lymphosarcoma is again very clearly is when there are a lot of hyperechoic areas in the liver with hypoechoic areas inside the liver capsule. Multiple areas will be there in lymphosarcomas. You will not be able to miss this diagnosis of lymphosarcoma. Whether it is spleen or whether it is liver, you can easily diagnose lymphosarcomas. Liver cirrhosis, I told you the liver border, see the liver border, they are all cirrhotic and they are not uniform, and you can see ascitic fluid, hypoechoic area surrounding the hyperechoic liver border. So this is very characteristic case of liver cirrhosis with ascites. Again, another case of liver cirrhosis with ascites. So when you look at the liver from the xiphoid angle, you look at the the darker line is the diaphragmatic line, and you see the gallbladder, and you see the on the left hand side you see the gallbladder, and you see the gallbladder wall also. But you have another structure which is bigger and having a defined when you'll have a granulated tissue, matter, which is hyperechoic. You'll have that material inside, which is purulent material within that abscess. So, but you should be always very careful. If you see up and down, then it is a mirror image of the gallbladder. It's an artifact. So you should be very careful in finding out whether it is an abscess or a an artifact. So abscess can be easily diagnosed. So biliary disease, cystic disease, cholestasis, cholangitis, gallbladder disease can be diagnosed with ultrasound. So this is some anatomy of the biliary system. Cysts have sharply defined borders, can be round or irregular, may contain hyperechoic areas. Coliliths, hyperechoic, aquatic shadowing. Any stones, you will have hyperechoic structure, and just beneath you will have a aquatic shadowing. See, this is a gallbladder stone. So you can see the gas filled area above, which is hyperechoic, and C is the stone, and beneath that you have A, which is complete shadow. So this is a classical picture of a stone. Whether it is in the gallbladder stone; if it is in the bladder, it's a bladder stone. Systolith. A similar pattern will be there. There will be a hyperechoic structure. Above you will have an hypoechoic area, and below you will have a shadow. See, again, I told you, an hyperechoic area within the gallbladder. You have the liver, you have the gallbladder, with a thickened gallbladder wall, and ventral part of it, you have an hyperechoic area, and which is being followed downward with a shadow. So this is very characteristic of gallbladder stone. If you move your transducer this way, that way, you can differentiate it if it is an artifact. So gallbladder mucocele is again a beautiful pattern called kiwi fruit pattern. This also you will not miss in your diagnosis. Within the liver parenchyma, if you see a structure like a kiwi fruit, it is highly suggestive of mucocele. And there can be sludge within the gallbladder. There can be a gallbladder wall thickening in cystitis, or there can be contents inside which are hyperechoic. That means it's got a gallbladder sludge. So vascular diseases which you can diagnose are venous congestion of the liver, right arterial mass, pericardial effusion, vena cava tumors. These are all going to cause post-hepatic hypertension, and all these things you'll be able to diagnose with the help of an ultrasound. Hepatic vein dilated, when you see liver ascites. Portovenicable shunt, there will be microhepatica. You have, I told you, you have both congenital portovenicable shunt and acquired portovenicable shunts. So young dogs, young kittens, you'll have congenital portovenicable shunts. So you can have microhepatica, bilateral renomegaly, nephron calcinosis. But you have bilateral renomegaly and nephron calcinosis in mostly acquired portovenicable shunts. Nephroliths and cystolith because of urate crystals. Ascites because of portovenicable shunt problem, because of the hydrostatic pressure. And shunting vessels are tortuous. So the vessels which are shunting, they will be tortuous. They will not be straight. Flow. Portal vein thrombosis. Again, this is very, very important. This you will develop over a period of time. So within the portal vein, if you keep following the portal vein from the abdomen to liver, you will be able to see an hyperechoic area within a black tubular structure, that is portal vein thrombosis. You can have even splenic thrombosis. Similarly, in the splenic vessel, you will have a hyperechoic small dot, that is a splenic thrombosis. These are all highly diagnostic of prehepatic portal hypertension or portal vein compression due to mass lymph node. So I'm talking about all these things before the liver, which causes ascites. This is called prehepatic portal hypertension. Before the liver, portal hypertension. So portal vein thrombosis, splenic thrombosis, portal vein compression due to mass, lymph node, AV fistulas, chronic, of course, chronic liver disease. Again, you'll have portal hypertension. That is hepatic portal hypertension. Diffuse nodular regeneration cirrhosis and infiltrative neoplastic disease. In all the last three, you will have hepatic portal hypertension. First three, you'll have pre-hepatic portal hypertension. The last three, you'll have hepatic portal hypertension. So you can see the dilated vessels, hepatic vein, because of hepatic congestion. You can see the hyperechoic, liver compared to normal liver. Okay, other tests which you can do are urine analysis. Unfortunately, most of the veterinarians, we do not do urine analysis. Urine analysis is going to give lots and lots of ideas, from simple specific gravity to protein. It gives us and presence of urobilinogen, is going to give us lots of ideas about the disease. Peritoneal fluid analysis is again very, very important. When there is going to be ascites, whether it is due to liver or whether it is renal or whether it is due to cardiac or whether it is due to peritonitis or whether it is due to some other problem, because ascites need not be need not be a distinction with fluid. It can be a simple distinction. It can have a gravid uterus. It can have a hepatomegaly. It can have a prostatic cyst. It can have a bladder rupture. Okay, it can have a simple peritonitis. So many things there will be ascites. You need not think about only portal hypertension and oncotic pressure. Okay. So absence of urobilinogen, very important. Presence of bilirubin in cats, highly pathological. Please understand, in dogs, presence of bilirubin in the urine is not pathognomonic. Don't jump to conclusion it is jaundice. Whereas in cats, yes, it is jaundice. Yeah, because off-life is very less and threshold for the kidney is very less. In cats, you see, definitely it is positive. In dogs, it need not be positive. Urate crystals, already told you, portovenic covered shunt. Highly pathognomonic for portovenic covered shunt. Presence of protein and specific gravity is very important in differentiating between renal, GI, loss of protein, renal loss of protein, and hepatic cause of protein loss. So this is again very important to find out which organ. So I told you effusion. Just simply submit a sample of peritoneal ascitic fluid to the pathology. If it is going to be no cells, no protein, it is pre-hepatic. If it has got moderate cells and moderate protein, it is hepatic problem. High protein content, high cellular content, cardiac problem. This is a major division. Of course, this is not diagnostic, but this gives you a lot of ideas. If there are not going to be any cells, if there are not going to be any protein, it is pre-hepatic. Look for a thromboembolism in the portal vein. Look for the embolism in the splenic infarct. You look for AV fistulas. You look for tumors comprising the hepatic veins. Okay, pre-hepatic problem. Moderate protein, moderate cellular. Think about liver. And classical diagnosis, your ultrasound, cirrhotic liver. If you have a cirrhotic liver, if you have ascites, if you have moderate protein and moderate cells, it is liver. Okay, if you have very high protein, very high cell count, and if you have Clinical signs of cardiac disease, like it has got tachycardia, it has got jugular positive pulse, it has got jugular pulse, all those things are there. There plus echocardiography, you can have a final diagnosis of post-hepatic portal hypertension. So you can differentiate pre-hepatic, hepatic, and post-hepatic with effusion with the help of other modalities. So liver biopsy and FNAC is the easiest method. Okay? Animal should be in right lateral recumbency. The right side should be on the table. Okay? Angle made by the xiphoid cartilage and the costal arch should be marked with a pen. Marked with the arrow mark. Okay. Now your needle, I will tell you FNAC first. Your needle should point towards cranially. Please understand, you can keep your finger and see. You just have it cranially, medially, direct towards medial side, and ventrally, downward. If you put the needle about 2 inches and take a FNAC with a spinal needle, you will get a wonderful fine needle aspiration. And there are no major problems in this method. You will not puncture anything. You will not be causing any discomfort. If you want, you can infiltrate the area with lignocaine. Otherwise, that is also not required. It's just like giving an intramuscular injection. Or if you want to infiltrate with a, lignocaine, local lignocaine. Another is the biopsy gun. TrueCut biopsy gun is available in human practice. It costs about 700 rupees, which is being thrown in human site, but we can reuse them by chemically sterilizing them multiple times. Okay? Here you require some skill. First, you should introduce a TrueCut inside the way I told you, cranially, medially, and ventrally for 2 inches. Then push the outer cannula, so inner cannula inside the liver capsule. Then the outer cannula alone should be pushed forward. It will cut a core piece and keep it inside, and then you bring it out. This requires definitely some skill. So you have to practice it in a cadaver. Okay? If you don't have that confidence, I have done for my PhD work, I did about 400 biopsies, and I have lost 3 cases. One in a small puppy, it punctured the vena cava. Another died later because of gallbladder problem. Another one, there's a severe bleeding because of hepatic capsule rupture. Out of 400 cases, there are three complications. Subsequently, I've been doing in my practice, I've never had any problem. And below is a picture of a biopsy gun. Of course, it is expensive. It may cost you around $700, $800 US. But here there is no requirement for skill. You just put the gun, biopsy gun inside and trigger shoot. That's all. All this forward moving, the outer cannula going inside, the left inner cannula going outside. All those things are done by the gun. You just have to trigger. So a simple investment of $600, $800 US, around 60,000 rupees. You have a biopsy gun, which can take wonderful biopsy specimens, where you get a wonderful histologic diagnosis of chronic hepatitis. So now diagnostic part is over. So you had clinical examination, where you see jaundice, ascites, hepatomegaly, then femoral pulse, jugular pulse, all these things you see. Then palpation, all those things you do. Subsequently, you come for biochemical, do a hematology. So you have whether it what hematocrit is low or not, you know that. Then you do bilirubin, you know that it's pre-hepatic, hepatic, or post-hepatic. Then you do enzymes, ALT and AST, find out if it's moderate, chronic, or severe. Then do ALP and GGT, whether it's a cholestatic enzyme. And you know what are the pretenders, in which disease you'll have, both ALT and ASP, like an example, Cushing's, all those things you have seen. Then you have seen urine analysis, you have seen peritoneal fluid analysis, that is abdominal centricity, you have seen that. And now you come to you have done the biopsy. Histopathology, I told you first itself, based on what type of infiltrates are there, is lymphocytic or eosinophilic or mast cell, what type of inflammation, whether it is mild, moderate, or severe, and if it is mild, with what are the symptoms to support lobular dissecting hepatitis, with what this one, what are the, how do you suspect liver disease and non-hepatic disease, how, where there will be a normal pathology, histopathology, and a normal enzyme, but showing signs. So that is reactive hepatopathy, not due to it's when liver. Okay, so I've seen all those things. Now come to treatment of liver disease. Eliminates a causative agent, whatever you think, whether it is viral or bacterial, whether it is toxins, whatever it is, eliminate the causative agent. Suppress the mechanism that potentiates a disease. Provide optimum conditions for hepatic degeneration. Control manifestation of complications that occur due to liver disease. So specific therapies: drug-induced recognition withdrawal of drugs, bacterial hepatitis, cholangitis, septicemia, antibiotics. So you have to think about this. You have to choose antibiotics in such a way that it does not cause toxicity to the liver. And since the liver is already dysfunctional, the antibiotic dose, we will see what antibiotic. And there should be an element of, logic in thinking about bacterial hepatitis, cholangitis, and septicemia. There should be some ALT increase. There should be some ALP increase. There should be leukocytosis. There should be a neutrophilia. Okay, all these conditions should be there for you to suspect bacterial hepatitis, cholangitis, septicemia, and therefore to initiate an antibiotic therapy. Okay, idiopathic chronic hepatitis, steroids. I told you, most of the times the steroids are an excellent choice for treating liver disease, especially chronic hepatitis, because it can be, it can be inflammatory disease or it can be immune-mediated disease. In neither of the case, steroids will be helpful. And sometimes when you don't have diagnosis, then steroid, when you give and they respond, it is immune-mediated. Colchicine, again, is an excellent drug which is not available in our country. Colchicine is a drug which is used by plant pathologists. It's a mitocidal drug where it stops multiplication of cells. So it is given, colchicine is given before the animal goes in for cirrhosis. Any chronic vector hepatitis, colchicine is a good drug of choice because it stops fibrosis and it's anti-fibrotic drug and stops cirrhosis. Cholestasis, whenever there is intrahepatic cholestasis or extrahepatic cholestasis, ursodeoxycholic acid is an excellent drug because there are so many functional effects for it improves the circulation of the bile. So cholestasis is improved. So there are a lot of pharmacological help which ursodeoxycholic acid. This is not my this is not the time where I'm going to say about ursodeoxycholic acid. But whenever you have intrahepatic, extrahepatic cholestasis, whenever there is increase in bilirubin, whenever you think there is a chronic hepatitis, you can use ursodeoxycholic acid. Copper toxicity, I told you, copper toxicity. Primary copper disease is seen in bed-linked interiors. Secondary copper sore disease is seen in Labradors and Dobermans and Dalmatians. So you can use deep insulinamide. These are all copper chelating drugs. Vitamin C is excellent drug. Trinitin is an excellent drug. It's a vitamin A analog. Zinc acetate is an excellent chelating drug for. So my personal choice is vitamin C injection. Whenever a dog where you suspect without doing any test, you think that it's a Doberman, it could be a problem with the liver, or it can be due to reactive hepatopathy. It may be a case of severe diarrhea where there is sepsis, where there is translocation of bacteria into the liver through the splenic circulation. And when you suspect, you can give vitamin C IV. So chronic copper toxicity, hepatic lipidosis. Okay, treat with lipotropic agents like B complex. Okay. Protein modification. So hepatic reserves or hepatic diet is all available nowadays. So high biological value protein can be given for liver disease. So you got human side, you got small sachets having hepatic reserves. Now you got our own one has got excellent hepatic resources, diets are there. Carbohydrate, easily digestible carbohydrate, fat restrict, provide essential fatty acids, fat soluble vitamins, fat soluble ADK, vitamin B complex, and zinc should be given. Treatment of hepatic crisis. So when the animal is showing ataxia, it is showing, circling, head pressing, all these things are, it's called, it is hepatic encephalopathy. So you want to treat them. So treat dehydration and GI bleed. So put them on a low carbohydrate diet, high biological value proteins. Start treating with antibiotics, where it is going to remove both the gut acting metronidazole and other drugs which reduces the gut bacteria, so that ammonia is not liberated, which is the most important cause of hepatic encephalopathy. IV antibiotics or oral antibiotics, lactulose to increase the sojourn of the fecal matter, so there is less time for absorption of ammonia. So treatment of hepatic crisis when there is ascites and edema. When there is ascites and edema, dependent part edema, think about low sodium diet, diuretics. We will see what diuretics. Paracentesis. So many of us have been questioning me whether ascitic fluid, you have to remove the fluid or not. We should never ever remove the fluid if it is not pressing the diaphragm and causing dyspnea. Because when you remove the ascitic fluid, you are removing a protein-rich fluid. So that means the oncotic pressure is going to be lost. Already there is some problem with hydrostatic pressure. Now you are reducing the oncotic pressure. You will remove 2 liters of ascitic fluid. Next day, it will be having 4 liters of more of ascitic fluid. So there is no point in doing paracentesis. In case you want to do paracentesis, you have to replace with colloids or albumin, human albumin, which is very expensive. But nevertheless, if there's a client who is willing to spend, you remove 1 liter of ascitic fluid and give 1 liter of plasma or albumin, human albumin. So ascites measure the body girth width, body weight, abdominal girth, PCV, total solids and burn, and start them on spironolactone. Don't use furosemide to start with, because furosemide, encapsulates ammonia and causes more problem. It, keeps ammonia within itself. So should never use furosemide. But spironolactone has got a weak diuretic action. So if it's got a respiratory problem and you want to remove it immediately, then it makes sense in clubbing spironolactone and furosemide. You got lacilactone, combination drug, or you put both that together. Okay. So that way you can reduce, furosemide and increase spironolactone, so that you can have a desired effect. If there is no response, PCV rolls a burn unstable, then you increase the spironolactone to 2 milligram per kg body weight, give 4 times daily. If still no response and PCV etc. is stable, increase the furosemide to 2 milligram per kg body weight BID. Watch for hypokalemia, because potassium sparing, furosemide. So dehydration you have to watch, because both your furosemide and spironolactone can cause severe, increase in urination and cause severe dehydration. Think about colloid administration, because that stays in the compartment. When there's a hydrostatic pressure is important, then it can definitely be a great resource. It can keep the hydrostatic pressure intact. Of course, plasma is very preferred, but the cost, okay, or albumin is most preferred, but the cost, all these things you should think about when there is no response in case of ascites and it's going to cause crisis. Therapeutic abdominal centers 18 gauge or 16 gauge catheter or open-ended tomcat catheter through a 14 gauge Teflon catheter. Remove over 1 hour, slowly remove, can improve efficiency of diuretics. Of course, you have a risk of infection, bleeding, loss of albumin, and hydrostatic pressure. All these things are there, but still hypotension. All these problems are there, but still you can do when there's going to be a compromise on respiration. If there's going to be hemorrhage and anemia, I told you, liver is organ involved in bleeding and clotting and lysis of fibrin. All those things is important. So when there's going to be a severe hemorrhage or anemia, you have to give vitamin K injections, blood transfusions, anabolic steroids, H2 blockers. So vitamin K deficiency possible with reduced hepatic function or cholestasis. In both the cases, you will have vitamin K deficiency. So you'll have to give vitamin K. Major bile duct obstruction. Okay. So 5 to 15 milligram total dose, intramuscular 3 doses, SID, or 0.5 to 1.5 milligram per kg, intramuscularly 3 doses in 12 hours. Then after recovery, 7 to 28 days as needed. You can do PIVECA test, PT and PTT to find out the problems. Okay. Cats 5 milligram or 0.5 to 1.5 milligram per kg. Intramuscular 3 doses quarterly, 12 hours. Then 1 to 2 times per weekly, PO until recovery. Watch for Ain's body hemolytic anemia. Vitamin K when you are giving, it causes hemolysis. So look for Ain's body hemolytic anemia. Monitor PCV RBC morphologies. When there's hepatic coma, treat with IV fluids, give enema so that more ammonia is not absorbed. Steroids, mannitol to bring down the CSF pressure, and nutraceutical drugs such as SAMI, Silimarin, liver protectants can be given along with the main treatment. So when to consider antibiotic therapy? When there's increased risk of infection, extrahepatic bile duct obstruction, chronic liver disease with portal hypertension, compromised hepatic perfusion and bile flow, enteric bacterial translocation, example bowel disease, bacterial dysbiosis, planktonic hypoperfusion. So in the absence of culture and sensitivity, cover aerobic and anaerobic enteric organisms, beta-lactamase resistance penicillins or metronidazole or clindamycin. You can go for aminoglycosides or fluorinated quinolones. Start treatment before if extrahepatic bile duct obstruction or known infection is there. Antibiotics that achieve therapeutic constant in liver and bile, renal excretion, amoxicillin 11 to 20 milligram per kg body weight intravenously or intramuscularly BID, cephalexin 15 milligram per kg body weight, either subcutaneously or orally or intravenously, endophloxacin in small breed dogs. Metronidazole, remember the dose should be reduced, the 7.5 milligram per kg orally, intravenously or rectal enemas or BID, TIDs, high bioavailability, water, wide tissue distribution is there. Note liver dose is 7.5 milligram. Important action against many urease producers. So it's most important thing, the important thing why we give metronidazole to reduce colonic bacteria producing ammonia. It is also got immunosuppressive activity. Overdose, cerebellar, central vestibular signs, seizures will be seen. Metronidazole, be very careful, especially in cats. Antibiotics to avoid, tetracyclines, lincomycin, erythromycin, trimethoprim sulfonamides, either inactivated by liver, require hepatic metabolism or can injure. To understand tetracyclines and doxycyclines, they have a double enterohepatic circulation. Okay, they absorb, goes to the liver, excrete in the bile, gets absorbed, again goes back, and therefore they can cause severe toxicity. Therefore, you want to treat leptospirosis when you suspect, then you should choose other drugs like potentiate amoxicillin to treat rather than doxycycline. Of course, you have no big choice when you're treating with Ehrlichia canis or Babesia, which can cause severe chronic active hepatitis. You have to use antibiotics. There's no problem. Okay? So gastric protectants used animals with chronic major bile duct obstruction at an increased risk of gastroduodenal ulceration and perforations. So H2 receptor antagonists like cimetidine at the rate of 5 mg per kg intramuscularly or IV or orally. Famotidine, they can also be given. Proton pump inhibitors like omeprazole is more potent than cimetidine and 0.7 to 2 mg per kg. SID, limited experience drug in cats. Metoclopramide, impaired hepatic function, decreases plasma clearance. Normal dose 0.2 to 0.4 milligram per kg. Okay. You can go up to 1 to 2 milligram per kg by CRI. 25% reduced dose 0.13 to 0.3 milligram per kg TID. Okay, or reduced dose by CRI. Ondansetron, good anti-emetic effect in patients with poor responsive to metoclopramide. Dose 0.1 to 1 milligram per kg orally 12 hours. Cats 0.1 to 0.5 milligram orally BID or SID. Glucocorticoids, I told you, chronic active hepatitis or chronic hepatitis is indicated. Antifibrotic, of course, weak. Non-septic active inflammation, you can give glucocorticoids. There should not be any indications of neutrophilia, leukocytosis, any other, suggestion that there is going to be a bacterial problem. The immunologic injury is there. If you suspect, yes, you can give. If you have symptoms of other immunological problems, then you can go glucocorticoids. It promotes bile flow, appetite stimulant, a sense of well-being, because the side effects, sodium water retention is there. If it is going to have more ascites, you cannot go for glucocorticoids. It's catabolic, increased susceptibility to infection, GI ulceration. They're all complications. So ascites or edema are a problem. Use glucocorticoids that lack mineralocorticoid. They can use dexamethasone. Okay, a tapered dose to lowest level. Can use azothioprine for immunosuppressive action when you think immune-mediated problems. More expensive than prednisolone, but steroid sparing. I told you about ursodeoxycholic acid in cholestatic enzymes, intrahepatic and extrahepatic. Is cholerectic, decreases proportion of toxic bile acids, reduces the immune response. Increased production of glutathione, methylathione in hepatocytes. Contraindicated in extra bile duct obstruction because there is no flow of bile. So increasing bile flow will be more contraindicated. 15 milligram per kg day divided in 2 doses. Indicated in cholestatic disorders, not in shunts or other diseases. Antioxidants, vitamin C as a pro-oxidant as well as a copper chelating drug. Yes, adenosyl L-methionine, SAMI, you all know very well about the drug, how it works as an antioxidant. Vitamin E, silymarin, N-acetylcysteine, zinc, UDCA, all these things are all drugs, antioxidants which you can use commonly in liver disease, chronic hepatitis. You know about this drug, the SAMI, and not tell you much. It's a very common drug which everybody are using. It helps to restore depleted GSH in hepatocytes. 20 milligram per kg, orally SID and empty stomach. Do not split tabs. Okay, so this is very important that you can use this drug, whichever form it's available. Silymarin again is an excellent hepatoprotective drug. It scavenges the free radical oxygens. So it saves from deteriorating hepatocytes. Cholerectic, anti-inflammatory, indicated where main damage to liver is oxidative. Vitamin E again, a dose is 10 to 15 internationals per kg per day orally. Indicated in liver disease associated with oxidative injury. Anti-inflammatory in nature, especially important in fat malabsorption, bile duct obstruction, copper toxicity, plasma toxicities. N-acetylcysteine, cytoprotective, along with SAMI, UDCA, and silymarin and vitamin E. Antioxidant, increases GSH, anti-inflammatory in nature, improves hepatic circulation, improves tissue oxygen delivery, given at the rate of 140 milligram per kg intravenously once, then 70 milligram kg per after 6 hours. I hope you guys are using N-acetylcysteine for various things, and acetylcysteine are good. I think I have even told you about how N-acetylcysteine is good for arthritis. So you should remember N-acetylcysteine should be a drug of choice for many diseases. Antifibrotic drug, I told you about this colchicine. It's an antimitotic drug used by plant pathologists. It stimulates collagenase, side effects, hemorrhagic, hepatic encephalopathy, bone marrow suppression, renal injury, and neuropathy. 0.025 to 0.3 milligram per kg SID few days, then UOD. Then either for the other day. No evidence that it helps. We don't know whether it helps or not, but nevertheless, it has been used by all developed countries over very many years. Don't use it if fibrosis is not the primary lesion. Anti-copper medication, I told you about, the breeds which has swam. I told you about all chelating drugs like D-penicillinamine, zinc, and I told you about vitamin C, tridectin, and everything I told you. So you can use them the dose rate given. Okay. How zinc gluconate or acetate is used. Okay, and you can use zinc gluconate or acetate for whenever you think of copper storage disease. So whenever you think there is chronic active hepatitis, in case of Dobermans, Dalmatians, and Labrador especially, you can use this zinc chelating drug. So what are the take-home message? Specific attention in high risk breed. So you should know that liver has got non-clinical signs, increased ALT, and initiate diagnostic steps, rule out extrahepatic causes, avoid or reduce hepatotoxic drugs. These are the common problems. What you're going to see is the common problems and how to approach it. Okay. So what are the common problems encountered by veterinarians? We see a lot of ascites cases. You see cases of jaundice. You have sometimes see hepatic encephalopathy where ataxia, head pressing, seizures all seen because of liver. And of course, shunts I'm going to talk little because required for high-end practice, referral practice. Okay, first of all, we should know there is ascites or distension. So all the dogs look like, it has got something in the abdomen, but you don't know whether it's fluid or anything else. So whether it is ascites or distension first. So what are the chances that it is not fluid? It is something else. It can be pregnancy, it can be pyometra, it can be hepatomegaly, it can be splenomegaly, renomegaly, neoplasia, obstipation, obesity, atonic bladder, GD, GDV. All these things will have distension, but there is no fluid. So distension with fluid. So there is fluid, but we don't know what it is. You may be having bile because trauma and cholangiohepatopathies. Blood can be there because of hemostatic disorder, trauma, especially when there is a trauma with the, I've seen a case of, a policeman kicking the dog on the costal cartilaginous arch, the spleen ruptured and a severe hemabdomen. So it can be trauma, neoplasia, coagulopathies, or it can be chylothorax, thoracic duct obstruction or neoplasia. Exudative or transudative fluids, urine, it can be there when there is an automobile accident. There can be a rupture of urinary bladder. Peritonitis, GI perforation or splenic torsions. So here all there's fluid, but not ascitic fluid. So how do you see this case? On physical examination, you are not very sure. Do survey radiography. Either you have effusion or you have organomegaly or muscle weakness. If there is effusion, you find it in the survey radiography. Then do a abdominal synthesis, whether it is a transudate or exudate. Pure transudate or modified transudate. Exudate, septic or non-septic. Okay. Then if it's going to be organomegaly, then you have to see what type of organ, hepatomegaly, hepatosplenomegaly. So what are the diseases which causes hepatosplenomegaly? And what are the chances that you have hepatomegaly? You have all this, differential diagnosis. Muscle weakness you can have in severe Cushing's disease, severe malnutrition, myopathy, and ruptured prepubic tendon. You can have muscle weakness. Once you have a transudate and exudate, I told you how to go about it. Send the cell content and find out it's got what cell count and what protein is there, and then seeing whether it is pre-hepatic, hepatic, or post-hepatic. So ascitic pathogenesis, oncotic pressure. I told you already the initial. Oncotic pressure is because of albumin. You can see them in reduced in protein-losing enteropathy or malabsorption, protein-losing nephropathy in end-stage kidney disease, malnutrition, end-stage liver disease. And all these things, there can be a reduction in oncotic pressure and ascites. Hydrostatic pressure, I told you, where there is going to be a block in blood flow from the intestinal area to the liver, that is pre-hepatic hypertension. In the hepatic liver, if there's going to be a block in the flow, it's called hepatic portal hypertension. From the liver to the heart and out of the heart, if there's going to be a block, it's called post-hepatic portal hypertension. I've told you about renal aldosterone activation system because of severe cirrhosis, where there's angiotensin aldosterone activation. So these are all the major vessels from the spleen, from the large intestine, small intestine, going to the through the hepatic vein to the liver, and from the liver to the vena cava to the heart and circulation. This is portal circulation. This is the same thing in a dramatic picture. Right side, from right side, transsplanchnic area, blood comes to the liver, detoxifies, goes to the heart and gets detoxified. So what are the pre-hepatic portal hypertension? Pre-hepatic portal hypertension, I told you, from the intestinal area before the liver, any obstruction to the flow of blood is going to cause hypertension. AV fistulas. This can be diagnosed only with a ultrasound where you have movement. Okay, then only you can find out AV fistulas. Lymphatic obstructions, intraluminal masses by ultrasound. Extraluminal compressive masses, that also you can see easily. Portal vein hyperplasia and portal vein thrombosis, lymphatic infarcts. These are all pre-hepatic portal hypertensions. And most important diagnostic for pre-hepatic portal hypertension, ultrasound is a major methodology for finding out what are the diseases which causes pre-hepatic. But to give some clues, your fluid, abdominal fluid, which has no protein, no cell count, then you think about pre-hepatic portal hypertension. Intrahepatic portal hypertension, there is inflammation, neoplastic infiltration, fibrosis. So here also the diagnosis purely based on ultrasound. Either there is cirrhosis or fibrosis or neoplasia, not a hyperplasia of the liver. You know there is going to be an increase in intrahepatic portal hypertension. Here, further in you will have your abdominal fluid will have moderate cell count, moderate protein. Your this one will support you. Your ultrasound, biochemistry will support you with a minimal increase in serum alkaline phosphatase, minimal increase in ALT, and minimum probably increase in bilirubin. All these things will be adding to your diagnosis of intrahepatic portal hypertension. So next is post-hepatic portal hypertension. From the liver to the heart, when there's going to be a block, post-hepatic portal, congestive heart failure. So there'll be tachycardia. Sometimes there may be VPCs. Then you will have clinical signs of ascites. Then you will have very high cellular count and high protein in the abdominal fluid. Then you have other clinical signs of hepatomegaly. You will have signs of what is that? Murmurs. All these things will be seen when you are seeing physical examination. Mitral stenosis, mostly by ultrasound, tricuspid insufficiency, vegetative endocardosis, pericardial effusion, all by echocardiography, cardiac tumors, diaphragm by doing blood test. Okay, so combination of all these tests along with ultrasound you will be able to pinpoint cardiac reason. Most important is echocardiography. You should have a good echocardiographic assessment to find out post-hepatic portal hypertension. All other things we will tell you support your diagnosis. There will be a mild increase in ALT because there's going to be, hepatomegaly. There's going to be a mild increase. All other things will be normal. Your serum alkaline phosphatase, your GGT, your protein, all will be normal. Oncotic. So oncotic pressure is the one I told you, protein losing enteropathy and protein losing nephropathy. You have to rule out malnutrition. So malnutrition, you will be able to find out from the history. If they are not been feeding a good source of protein, then you usually some clients bring puppies with pot-bellied and ascites. If you ask them what they're giving milk, they're giving rice, they're giving curd. So no protein. So they might have ascites. So you should know about that. So history, slow development with rapid development. Slow development, in most of the cases of cardiac cases, slow development. Rapid development in prehepatic portal hypertension. Dyspnea, wasting, polyuria, polydipsia, diarrhea, vomition, cough, exercise intolerance. These all give you some, ideas about what type of problem is there. I told you about palpation, ballotment, subcutaneous edema, femoral pulse for ruling out cardiac disease. Full cardiological examination, distended jugular vein, jugular pulse, murmurs, pulse deficit. I think we are talking about pulse deficit. Difference between heart rate and pulse rate. That is called pulse deficit. If heart rate is going to be 120 and if your pulse is going to be 100, there is a loss of 20, where it has gone. So there is empty beating of heart. There is no pulse. So this is highly suggestive of congestive heart failure. Of course, if you have CVP measurement, when you can do a central vein, you can put a central vein and attach the central vein pressure monitor, then you can find out about cardiac disease. Hematology, total plasma protein, albumin, renal function, hepatic enzyme, pancreatic enzyme will all rule out extrahepatic causes. Protein specific gravity, urine protein creatine ratio. This will help you major way. I'll tell you, we'll see what it is. I told you about effusion, how it is no cell and no protein in prehepatic, moderate cell and moderate protein in liver, and high protein, high cell count in this one. That is easy. So this is again very important. Plus it has got pleural and pericardial effusion. The same case has got both ascites, pleural effusion. Then you should do an echo, and if it is suggestive of cardiac disease, then you have a treatment for that. And you have only abdominal effusion, then you have to evaluate the liver. If it is the evaluation is abnormal, then it is liver disease. Okay. Then you do a serum albumin. If it is less than 1.5 grams, then evaluate the liver. Okay. If it is normal, it is protein losing enteropathy. Okay. If is less than 1.5 gram, your urine protein urine creatine ratio is normal, then again come back to evaluating the liver. Okay. It can be mostly PLE or liver. If the urine protein and urine creatine ratio is increased, then it is protein losing nephropathy. Then find out what are the diseases where you usually end stage kidney disease. This is how you do serum albumin, ascitic fluid, and echocardiography to find out the cardiac disease, liver disease, or whether it is a renal disease. Very simple way to find out ascitic fluid and echocardiography and serum albumin. This is enough. Abdominal fusion analysis, I already told you about that, so you don't have to worry about that. So this is a case of Great Dane having severe ascites. So it has got tachycardia and small R amplitude and acute deepening. Okay, okay. These are all suggestive of congestive heart failure. Radiography will tell you about ascites, hepatomegaly. So abdominal ultrasound echocardiography. So ascites with you can how to diagnose ascites. We already told you. Liver tumor with abdominal effusion, chronic cirrhosis. This you already seen. Hepatic congestion, distracted vessels, hepatic veins. So you have all the hyperechoic borders of liver seen. Gallbladder wall thickening. So liver tumor ascites with lymphosarcomas. This you have already seen. This is a paraprostatic cyst where there's abdominal distension. There's no ascites because of a paraprostatic cyst. It looks distant abdomen. The chronic kidney disease with ascites where there's going to be hyperechoic cortex. And if you see Bhanu creatinine, urine protein creatinine ratio, all those things will tell you it's got a renal disease. Pericardial effusion and ascites. So if you have, I told you, pericardial effusion, pleural effusion, ascites, most often it is because of cardiac cause. Mitral regurgitation, again, is very easy to diagnose with echocardiography, Doppler echocardiography. Uterine mass and pyometra. Of course, treatment I've already told you about that. We have seen. Abdominal synthesis also, we think you know how to do abdominal synthesis. Okay, this is all we have seen all these things. Most important thing I want to go to. You have seen all these things. Don't bother about this. Nephrotic syndrome or protein, how to treat protein losing enteropathy, nephrotic syndrome and all. So we do not bother. Hepatic encephalopathy. So clinical signs: ataxia, change in mentation, circling, atrophy, all these things. Fluid therapy treats seizures, mannitol, antibiotics, lactulose, hepatoprotective drugs like SABI. So 2.5 dextrose and 0.5% normal saline. Don't give ringless lactate. Give mannitol to decrease the CSF pressure. Antibiotics, metronidazole, amoxicillin as a better drug of choice. Reduced dose. Soapy enema, vitamin K, maize or famotidine, SAMI, N-acetylcysteine, lactobacillus. Okay, now we'll come to jaundice. So we have seen ascites, how to see. So how to rule out renal, cardiac, malnutrition, and liver disease. We have seen. So now jaundice, pre-hepatic, hemolytic. So but what are the cases of hemolytic jaundice? Immune-mediated hemolytic anemia, babesia. So immune-mediated hemolytic anemia, you can see in I don't test is there. You can have other tests to do IMHA. Babesia, you can of course do PCR. Hepatic, leptospirosis and chronic hepatitis. Drugs and breed specific. Jaundice if it is there. So if you have history of any drugs, you can always know that. Post-hepatic bile duct obstruction, stones, pancreatitis. Clinic examination, mucous brain, abdominal palpation, effusion, hepatomegaly, splenomegaly. So in hematology, regenerative anemia, non-regenerative anemia, Coombs test, SAP and GGT, blood smear and serology albumin, and one will help you to differentiate. Radiograph and ultrasound, biopsy, histopathology. Leptospirosis, which is very, very commonly thought of in our case, which causes renal failure, which causes jaundice. And I just want you to understand something about leptospirosis. So leptospirosis, though it is jaundice, it is not because of hemolysis. Hemolysis is seen in babesia. Leptospira causes intrahepatic, narrowing of vessels and thereby intrahepatic, cholestasis. So leptospira mechanism of causing jaundice and babesia causing jaundice totally different. In leptospira, you will have leukocytosis and you will have normal PCV, normal hemoglobin. In hemolytic anemia and babesia, you will have very high bilirubin and you will have PCV, very low PCV, and you will have hemoglobinuria, all those things. So you understand how to differentiate between leptospira and babesia. Okay. So leptospirosis, pathogenesis, hepatic failure, disseminated intravascular coagulation, all those things leading on to CKDs, all those things, you all know that. So what are the different diagnostic, MAT, PCR, biochemistry, dark field microscopy? Okay. Icterus on presentation is rare. I told you it's very rare because here there's going to be only intrahepatic cholestasis. Your bilirubin will be not more than 2 milligrams, so it may not be visible. MAT again does not confirm because vaccine induced increase, subclinical or persistence of antibodies. MAT negative in the first week. PCR is good. So this is a basic, diagnostic. If you have facilities to do PCR and MAT, what you should do? History, physical examination, clinical examination, CBC, biochemically and urine analysis and ultrasound. Start them on doxycycline. Submit for PCR, urine and specific urine and serum. Okay, if it is PCR negative, submit MAT. MAT negative, repeat after 7 days. MAT positive, less than 800. Second MAT negative, unlikely lepto. Okay. MAT positive, more than 600. If it is vaccinated or unvaccinated. If it is vaccinated, again go for repeat MAT. If it is no, lepto is questionable. And if PCR is positive, then leptospirosis is positive. So this is how you'll have to diagnose leptospirosis. You should have MAT and PCR facility in your place, and this is how you diagnose leptospirosis. Having diagnosed leptospirosis based on history, physical exam, clinical examination, CBC, you have a mild increase in bilirubin, mild icterus is there, leukocytosis is there, neutrophilia is there, you have minimum ALT increase, then you think about all this, MAT and PCR, how to do MAT, how to evaluate MAT less than 800, type 1 and 800, how to evaluate MAT 1 in 1600, and how it is PCR if you have facilities, what if negative, what if it is positive. This is how the algorithm for diagnosis of leptospirosis. Of course, portosystemic shunt, I told you about the shunt, how it goes from the pancreas, intestines, spleen, all those things have to go straight to the liver, from there to the hepatic vein to the heart. Instead, there's blood going from the splanchnic area directly to the caudal vena cava, bypassing the liver. It can be from the umbilical artery, it can be from the spleen, it can be from the main, main abdominal vein. Anything, it can be shunting vessel. It can be also shunting inside the liver. So intrahepatic and extrahepatic shunts, both are there. So what invariably, I just told you, okay. So these are all the different types of shunt. Okay, I don't want to go deep into it. Intra is extrahepatic shunt. I don't want to go deep into it. Generally, what we do is, I will tell you about Sven. There will be stunted growth, depression, disorientation, seizures after a protein meal, hypersalivation in cats, ataxia, blindness, all these things will be there. Ascites, urolithiasis, crystals, all these things will be there in a clinical case. Okay. Once you see this, there will be a microcytic anemia. Some others, bile acids will be inside, ammonia will be increased. Okay, all these things will be there in biochemical examination. Once you see them, then you have to refer it to an hospital where they'll, take a jejunal vein and put a, small needle and inject a dye. Okay. After injecting dye, they have to take X-ray on the theater itself. Okay. And if it has got a bypass, then this ligation is temporarily closed with a knot. And this vessel is also attached to the portal manometer. If the portal pressure increases more than 14 mm pressure, then there's no point in ligating the vessel because it will anyway form other roots and increased portal hypertension will be there. So we'll have to manage them only medically. If it is less than 14 mm, then you can ligate them. So that is a method followed about 15-20 years before. They were doing almost every day 3-4 cases of shunts they'll be doing when I was in England. Subsequently, now you have got a lot of advanced things like there'll be a constrictor. Just you apply that constrictor and gradually it will constrict, so that the portal hypertension will not be there. And there are stents to be placed where the shunting vessel can be stopped. So all these recent developments have taken place. But I do suspect whether anyone is doing shunts in India. If someone knows, maybe they can tell me. As much as I have never done, so I have seen in England, so I do not know if anybody is doing it yet. But nevertheless, we should know what is portovenous ultrasound, what are the diagnostic tests. This is a photography where the jejunum vein is catheterized, and through the catheter, contrast agent is injected, and you see the shunting vessel. So medical management: lactulose, diazepam, and levetiracetam for seizures, reduced protein feeding, intestinal protectants, oral antibiotics, hepatoprotective drugs. Surgical management: I told you, ligation of the shunting vessel, ameroid constrictors. These are also ameroid constrictors, where it constricts a shunting vessel. Okay, this I don't want to take. Any questions? I'll be more than interested in. So I have talked to you about generally about liver disease, how difficult it is to diagnose, and how to interpret the results by and large. Mainly, what we should know is alkaline phosphatase, ALT, AST, total protein albumin, how to interpret them. Of course, we should have a good ultrasonology. Then, of course, we need to do, other things like abdominal effusion, urine analysis, which all supports towards this one. And we should know what are the diseases which are available, and we should know to suspect hepatic disease so that we can use all this together.